Now, most patients with locally advanced laryngeal squamous cell carcinoma should be offered organ preservation, which is delivered with a combination of chemotherapy and radiotherapy. However, some patients with very advanced disease like T4 or extensive T3, or those who have poor pre-treatment laryngeal function, those patients would do better with total laryngectomy rather than chemoradiation. Now, for patients with intermediate risk factors, including T3, T4, perineural invasion, lymphovascular space invasion, multiple positive nodes, soft tissue extension, and close margins, these patients need adjuvant radiotherapy alone. And this is per the NCCN guidelines 2024. A subgroup of patients who have high-risk features, including mainly positive margins and extranodal extension, these patients will do better with concurrent chemoradiotherapy. And we're gonna go through the data. So these studies are old. Two studies, the RTOG and the ORTC, published around 20 years ago. I'm gonna start with the first one, the RTOG 9501. It was an intergroup phase 3 trial. It included patients with squamous cell carcinoma of the oral cavity, oropharynx, larynx, and hypopharynx. These patients underwent macroscopic complete resection, and the high-risk characteristics in this trial were defined as having more than 2 or equal to 2 positive lymph nodes, extracapsular extension, microscopic involved mucosal margins. And these patients had to be able to tolerate chemotherapy. The randomization was after surgery to either radiotherapy alone, a dose of 60 gray in 30 fractions, plus or minus a 6 gray boost to the high-risk sites, versus the same radiotherapy along with concurrent cisplatin, high-dose cisplatin, 100 milligram per meter square, giving on day 1, 22, and 43, which means every 3 weeks. So the results of the study, it showed statistically significant improvement on local and regional control, 82% versus 72% in the combined therapy arm. There was also improvement in disease-free survival with a hazard ratio of 0.78 that was statistically significant. As for overall survival, it was not different between the two arms. In terms of adverse effects, grade 3 or more acute toxicity were almost doubled with the use of concurrent chemoradiotherapy, 77% versus 34%, p-value less than 0.001, as were hematologic, mucous membrane, and GI toxicity more frequent in the chemoradiation arm. Late toxicity was similar between the two arms, 17% versus 21%. There was no deaths in the radiotherapy arm alone. 4 patients, which is equal to 2%, have died from during chemoradiation. They also published in 2012 the long-term results of the 9401. And when we looked at long-term follow-up, there was no difference between radiotherapy and chemoradiotherapy for the entire group. There was no difference either in local recurrence-free survival, disease-free survival, and overall survival. But when they performed an unplanned subset analysis limited to patients with positive margins and or extracapsular extension, there was still a statistically significant difference in terms of local regional failure and disease-free survival favoring chemoradiation. Again, overall survival was not different. Moving on to the next randomized trial, which is the ORTC 22931, published in the New England Journal of Medicine in 2004 by Bernier et al. It was a similar trial. It included histologically confirmed squamous cell carcinoma treated with surgery with curative intent. Again, included patients with oral cavity, oropharynx, hypopharynx, and laryngeal cancer. The high-risk factors in this trial were defined as positive margins, perineural invasion, vascular embolisms, or extracapsular extension, patients between 18 and 70 years with a good performance status of 0 to 2, and they ought to have normal hematological liver and kidney function. And this is the randomization scheme. Post-surgery, patients had either radiotherapy alone or radiotherapy with the similar cisplatin, 100 milligram per meter square every 3 weeks. Primary endpoint, disease-free survival. Secondary endpoints, overall survival, local control, acute and late complications. In terms of disease-free survival, The combined therapy arm did better with a p-value of 0.04. In this trial, in contrary to the first one, there was an improvement in overall survival, 53% versus 40% at 5 years with a p-value of 0.02. There was also improvement in local and regional relapses, 31% versus 18%, favoring the combined therapy arm. In terms of toxicity, it also doubled in this trial, 21% radiotherapy alone versus 41% in the chemoradiation arm. In terms of mucosal toxicity, more than grade 3. There was also other toxicities, including leukopenia, dysphagia, shoulder syndrome, nausea, etc. Late toxicity was similar between the two groups, 5% versus 10%. It was numerically different, but non-statistically significant, as well as xerostomia, 14% in the chemorad versus 22% in the radiation therapy arm. Now, because of the difference in outcomes in these two trials, and because also there was some difference in the inclusion criteria, a pooled analysis was done combining data from both RTOG and EORTC, and a comparative analysis of the selection criteria, clinical and pathological risk factors, and treatment outcomes was carried out. So when we look at the differences between the two trials, there was major differences in terms of the end stage. More patients in the EORTC had N0 or N1 disease, 43% versus 6%, whereas on the other hand, way more patients had N2 and N3 disease, 94% in the RTOG versus 57% in the EORTC. So when we look at the results, it seems that the strong predictors of response of benefit to chemoradiotherapy was the presence of extracapsular extension and positive margins. Whereas there was, for the patients who had more than 2 involved lymph nodes without extracapsular extension as the risk factors, they did not seem to benefit from concurrent chemo. There was a trend for benefit for chemoradiation in patients who had stage 3 and stage 4 perineural invasion, vascular embolisms, clinically enlarged level 4 and level 5 lymph nodes, and secondary to tumors arising in the oral cavity and oropharynx. So to conclude, the strong indication for concurrent chemoradiation is the presence of ECE and positive margins, whereas all other patients are ought to be treated with radiotherapy alone. There is a bit of controversy for patients who have positive lymph nodes. So in addition to this randomized trial, there was a retrospective study from Dr. Mendenhall and his group that published that patients who have multiple lymph nodes might have incremental improvement with the use of chemotherapy, but still this is not randomized data, and we do it on a case-by-case in our clinic. What about the choice of concurrent chemotherapy? In the RTOG and the EORTC trial, cisplatin was given high dose, 100 milligram per meter square every 3 weeks. And in this randomized trial from the Japanese oncology group, they ought to compare cisplatin high dose every 3 weeks versus cisplatin low dose weekly. And this is the scheme of the trial. It included patients with high-risk squamous cell carcinoma of the head and neck, pathological stage 3 and 4, microscopically positive margin, with or without extranodal extension, including primary sites from the oral cavity, larynx, oropharynx, and hypopharynx. The randomization was radiotherapy, 66 gray and 33 fractions in both groups. The randomization was between high-dose cisplatin every 3 weeks versus low-dose cisplatin, 40 milligram per meter square every week. When we look at the results of the study, numerically, the use of weekly cisplatin low dose is better than the old way, 3 weekly high dose. But again, let's remember, this was a non-inferiority trial, so we can say that at least it's not inferior. The same goes for relapse-free survival and local relapse-free survival, where numerically patients with weekly cisplatin did better. And the message from this trial was that the new standard of care is to use low-dose cisplatin, 40 milligram per meter square weekly. In terms of toxicity, the use of weekly cisplatin also led to lower toxicity in terms of neutropenia, and also in regards to the rates of dysphagia, nausea, infection, as well as hyponatremia, renal impairment, and hearing impairment. Moving on to the practical part. So in terms of immobilization and CT simulation, we put the patient on the treatment couch in a supine position with the neck hyperextended. We put wires on the scar and we put a 3 mm bolus over the scar. We prefer to keep the trachea in the tracheostomy, and it is used as a self bolus. We use the pull straps for shoulder retraction, and definitely the thermoplastic mask to the head and shoulders. Moving on to the delineation, whether for the target or organs at risk, there are now some online resources that are useful, especially for residents and trainees. And an important one is called the e-contour, and I've added a link here in the PowerPoint presentation. And in this one, you have the delineation of the normal tissues cut by cut on axial CT scans. And this is in addition to some guidance also on target delineation. And this goes for laryngeal cancer, oropharyngeal cancer, actually all head and neck cancers, and also for other primary tumors, including breast, GYN, etc., etc. So in this e-contour, you can see on the left side of the slide all the normal tissues that we usually contour in head and neck radiation oncology. And it also puts some descriptives on how to delineate these organs at risk, in addition to visualizing the contours on the e-contour. Now, in terms of radiotherapy targets, we usually treat the larynx tumor bed, the involved lymph node bed, and the leg lymph nodes at risk according to the end stage. Most of the data we use is from definitive radiotherapy guidance. I mentioned in this slide a paper by Vincent Grégoire published in 2018, which gives a description on how to delineate the neck levels according if the patient has N0 disease or N1 disease, N2A, N2B, N2C, etc., etc. I'm not gonna go into the details. Moving on to the radiotherapy dose, our practice at our institution is to treat patients with intensity modulated radiotherapy using simultaneous integrated boost. And these are the doses that we use. So for patients for areas of previous gross disease, tumor bed, and involved lymph nodes, we deliver a dose of 60 gray in 30 fractions. For the uninvolved operative bed, let's say a dissected neck, but that it's negative, the prescribed dose is 57 gray in 30 fractions. And finally, the areas that are not dissected but seem to be at risk, we deliver a dose of 54 gray in 30 fractions. For the instances where we have a positive margin, we push the dose towards 66 gray. And then when we have extracapsular extension, we also push the dose to somewhere between 3.6 to 6 gray to improve our local control. I'm illustrating here a few cuts of a radiotherapy plan for a patient who is treated with adjuvant radiotherapy. And you can see here the areas that receive the high dose in green, and then the intermediate dose in red, and finally the yellow shows us the low doses, the 54 gray. Now here you can see that we are treating the retropharyngeal lymph nodes, which is unusual for laryngeal cancer, but this patient had involvement of the hypopharynx, and we had to chase the RP lymph nodes all the way to the base of skull. Now, in terms of plan evaluation, we all use the dose volume histogram to extract the data on the exposure of normal tissues to radiotherapy. We use our dose constraints that are published. This is a table from the NCCN Guidelines 2024 that gives the allowed dose to the normal tissues, which will keep the risk of toxicity, whether early or delayed, to as low as possible. In terms of side effects, most of our patients develop acute side effects, which are radiation dermatitis, mucositis, esophagitis, xerostomia, dysgeusia, hair loss, and fatigue. A skin reaction can be mild to moderate during the first few weeks of radiotherapy, but at the end, some patients can develop really significant skin toxicity, as I show on the right side of the slide. In terms of late side effects, these patients may develop xerostomia, dysphagia, aspiration, teeth decay, osteoidonecrosis, hearing problems, visual problems, fibrosis, neck stiffness, trismus, thyroid dysfunction, vascular complications. So as you see, there's a lot of toxicity that could occur after radiotherapy. I think we don't have the time to discuss those in details, but I will be happy to take any questions. And I thank you for your attention.
Thank you, dear Dr. Bassem, for your excellent presentation, for pointing the indications for radiation alone, for concomitant chemoradiation therapy, for going through the clinical evidence, radiation details, and toxicity. I have one question. Which situations do you include 1B and retropharyngeal in your practice in the elective target volume?
Yeah, that's an excellent question. So we don't typically treat level 1Bs. The exceptions are when we have bulky lymph nodes that are present at the level 2A in the neck. In terms of retropharyngeal lymph nodes, whenever we have extension of the tumor to the pharynx, whether hypopharynx or oropharynx, which is unusual, we have to include the retropharyngeal lymph nodes because the drainage would also follow the routes of those primaries, whether hypopharynx or oropharynx. This is when we do it actually in these exceptional cases.
In some unusual situations, we have some patients with an early recurrence after surgery. How do you evaluate these patients post-op? If there is any gross disease evident by post-op imaging, would you change your radiation dose, type of chemo, and the treatment?
So your question is about the patients who develop a rapid progression, let's say 3-4 weeks after surgery, right before
Yeah,
the radiotherapy.
before radiation, yes.
Wow, so that's a challenging scenario. We have had a couple of similar cases over the past years. It's unusual, but you see it in some of those aggressive, rapidly proliferating tumors. And in those cases, we have to differentiate two scenarios. The first one is a true progression, and the second one is disease that is left and was not resected during the surgery. As you know, we have many patients who come from outside our institution and they have their surgeries done elsewhere. So if the scenario is that, let's say, the patient has a lymph node that was not resected during the first surgery, our approach is to complete the resection and then offer radiotherapy as planned. Now, for those who have these rapid progressions of their disease, one of the considerations is to either give concurrent chemotherapy and give a high dose to these tumors as we give for gross disease, which is 70 Gray in our practice. The second approach is to use induction chemotherapy. You know, in laryngeal cancer, it's an accepted approach to use induction chemotherapy before radiotherapy or chemoradiotherapy, as was published in the 9111 randomized trial. So it would be a good idea for these rapidly proliferating tumor to start with induction chemotherapy and then offer radiotherapy afterwards, whether radiotherapy alone or preferably concurrent chemoradiotherapy, if the patient can handle the treatment. I'm not sure what's your approach in those scenarios.
Yeah, actually, I routinely do post-op imaging for my patients, just specifically for patients who have positive surgical margins, just to make sure that there is no gross disease left and there is no evidence of early recurrence, because it's really the first treatment always is the best treatment.
Absolutely, I fully agree.
So thank you, Dr. Bassem, for your attendance, for your sharing your presentation. And now we will